We have data at this point from four of the five health partners or data partners or insurance companies that we partnered with. So four of the five companies we have data for. The fifth, we're still working on analyzing the data. But within the four out of five data partners that that had responded or that we have data for, we have over 47,000 patients that were randomized to this early intervention versus delayed intervention. And across the patient population, we found that that 67% of these patients were treated with an anticoagulant. At the time that we were identifying them. So within the four out of five data partners, 67% of their patients were on an anticoagulant, and then that left us with these 47,000 patients that weren't on an anticoagulant and were randomized. And so within those patients, the patients, given randomization were well balanced in both groups. The mean age was 78 years. We had about half of the patients that were female sex. It was a really high risk patient population, which I think is important. So the mean CHADS VASC score was 4.5, and nearly half of the patients had high risk atria score of greater than or equal to 5, so high risk for bleeding, and about 20% of the patients had a history of a bleeding related hospitalization. And you had said early on that the expectation was that the early intervention would result in higher rates of initiation of anticoagulation, and actually, unfortunately, that was not true, and we were somewhat surprised about that as well. The final data showed for these four data partners that about 10% of patients initiated anticoagulation over the course of follow-up in both arms. And so there was no statistically significant difference. Now, if you haven't seen the data for the study yet, one of the things that we did see was we looked across various time points for initiation of anticoagulation. And so we looked at 42 days, at 90 days, and at 183 days. And we looked at what the initiation rates in both arms were at each of those time points, and there were no statistically significant differences across any of those time points. However, there were numerically more patients in the early intervention arm that were started on anticoagulants early after the intervention was done, and that difference, that numerical number, was sort of attenuated over time. So I think that one of the things that we noted was that given that there was that numerically more patients were initiated on anticoagulant early after the mailing, it at least raises the question of whether multiple mailings or further contact with these patients would have been more beneficial. We did look at clinical outcomes as well. Those were secondary endpoints looking at stroke and bleeding events and all-cause mortality. And not surprisingly, given that there was no difference in the primary endpoint of anticoagulation use, there was no statistically significant difference in any of those secondary clinical endpoints as well. So I think, from our perspective, one of the main goals of this study was to show that it was feasible to identify, enroll, and obtain outcomes through this extremely novel study design using this FDA Catalyst network. And again, part of what's so unique about this network is that our queries are sent out, data queries are sent out to the insurance companies, and the insurance companies run the queries behind their own firewalls and their own data, and they only send back aggregate data. And so the DCRI was the analytics center that ultimately did the meta-analysis, but the DCRI did not have any patient-level data. So no patient-level data ever left the insurance companies themselves, which, again, was a really unique aspect of the trial. So the other thing that I guess I would emphasize is that although there was no statistically significant difference between the rates of oral anticoagulant initiation with the single education mailing, the rates of initiation were low in both arms. So only 1 in 10 patients initiated an anticoagulant over the course of the study. And so we really do need more approaches and more interventions that will address this major public health issue.